Welcome to this UCL lunchtime lecture on the antidepressant controversy. My name is Essi Wieding. I'm Vice Provost for Mental Health and Wellbeing Grand Challenge here at UCL, and I will be chairing today's lecture. As many of you know, World Mental Health Day is recognized annually on 10th of October, and this year Workplace Health is running a campaign that aligns under the Healthy Mind theme of being well at UCL. The year's theme is promote, prevent, and support, prioritizing mental health in the workplace. And as part of the campaign, Workplace Health and the Grand Challenges have collaborated to bring you 4 lunch hour lectures on a range of topics relating to mental health and some of the challenges that are faced across the mental health landscape. These talks embody the whole university approach towards mental health support outlined in the recently agreed UCL mental health principles. The principles are the next strategic step to creating a healthy culture for both staff and students here at UCL. Today is the 4th and final talk in this series, and it's my honor and pleasure to introduce today's speakers, Dr. Gemma Lewis and Professor Glyn Lewis, not related to each other. Dr. Gemma Lewis is a psychiatric epidemiologist in the Division of Psychiatry at UCL Faculty of Brain Sciences. Her research focuses on the causes, treatment, and prevention of depression and anxiety. Most people experience these mental health problems for the first time during adolescence, and much of Gemma's research focuses on children and young people. She is currently a Wellcome Trust Sir Henry Dale Fellow, investigating the association between academic pressure and adolescent depression, anxiety, self-harm, and suicide. Glyn Lewis is Professor of Epidemiological Psychiatry in the UCL Division of Psychiatry and former Director of the division. He investigates the causes and treatments of depression and anxiety and leads randomized control trials to evaluate treatments for depression and anxiety in primary care. His research aims to have practical implications in improving clinical care or informing public health while identifying advances in neuroscientific understanding that could lead to practicable benefits for patients. Before we begin, I wanted to let you know that we will have some time at the end of the lecture for questions, and these can be submitted at any point during the talk by going to Slido. You can enter this into your internet browser and entering the event code, which is controversy. I will now hand over to Glyn and Gemma for their talks, and I hope that you will be very informed and interested in the talks, and that you will indeed submit questions.
Okay, thank you very much, Essie. I'm just going to share my slides. Okay, so we're going to be talking today about the antidepressant controversy. So I'm going to start by talking about depression and antidepressants. So depression is a very common mental health problem that is estimated to affect 280 million people worldwide. And one of the first treatment options for depression is an antidepressant. And we know that prescriptions for an antidepressant have risen substantially over the past 20 to 30 years and are continuing to rise now. And I just wanted to show some snippets of some news articles that have reported on this rise in antidepressants, just to illustrate that because depression is so common and antidepressants are so commonly prescribed, there's usually a large public interest and media interest in the use of antidepressants. And here's just some examples of the wide reporting on the increase in antidepressant prescriptions that has occurred in recent decades. And here's the evidence to illustrate that. So this was a research paper that found that the rate of antidepressant prescriptions started to increase in the mid-90s, continued to rise up until 2011. And then we've got more recent data showing that one of the most common antidepressants here, called sertraline, has been increasing from, in terms of the number of items prescribed, from 2015 all the way up to 2019. And then a more recent study showing that the increase in prescriptions has been continuing up to 2021 and 2022. So antidepressants in the media. So there is a large public and media interest in antidepressants, but antidepressants often receive quite a negative press. So here's a few examples of quite negative, stigmatizing headlines about antidepressants. So, for example, a nation hooked on happy pills, stop dishing out pills for depression, and misery cure in doubt, the pills don't work. And on social media, there's a perhaps even more polarized debate about antidepressants, and this is particularly evident on X, which was formerly Twitter. There's an ongoing debate, and the issues that are involved in this debate have remained the same for some time, and mainly they include how effective antidepressants are at treating depression, the side effects that antidepressants may have, withdrawal symptoms when people stop taking an antidepressant, and also the number of years that people can often remain on antidepressants. So just to summarize some of the criticisms of current evidence on antidepressants, these criticisms, can be described in sort of three different points. The first point is that the effect that antidepressants have on people's symptoms of depression is not large enough to make a difference to how that person feels. The second criticism is that in clinical trials of antidepressants, where people join the study and they're then randomly allocated to either take the drug in question, so they actually take the medicine, or they're randomly allocated to a different group where they take a dummy pill or called a placebo. The other criticism is that in these trials, because antidepressants have side effects, people can often figure out which group they've been allocated to when they aren't supposed to know. And this unblinding, as we call it, can bias the results of those trials. The third issue is that when people stop taking an antidepressant, any potential relapse of their symptoms could potentially be confused with withdrawal symptoms from stopping the antidepressant, because these two sets of symptoms overlap quite substantially. So I'm going to talk today about some of the evidence that relates to each of these points. So firstly, I'm going to discuss the first point, which is that the effect that antidepressants have on people's symptoms of depression is not large enough to make a difference to how they feel. So in 2018, there was a study that synthesized all available evidence on antidepressants. And this is a type of study that's called a meta-analysis, and it was led by Andrea Cipriani and his colleagues in Oxford University. And they collected data from 522 clinical trials. And these clinical trials had data on over 116,000 people. So all available trials, whether they were published or not published, whether they were by pharmaceutical companies or not by pharmaceutical companies. And this study as well got a lot of media attention and a lot of, some of it quite positive attention. So the overarching finding was that the study found that 21 commonly used antidepressants were all more effective at reducing symptoms of acute depression, so depression that occurs over a specific period of time, rather than compared to a dummy pill or placebo. So antidepressants were more effective than the placebo. We've just got a quote here from one of the BBC article about this study. So antidepressants often receive a bad press, but this paper shows that they do have a role in the management of people with depression. I just wanted to show some data to illustrate the main findings of the study. So you can see the most commonly prescribed antidepressants circled in yellow here. So these are the SSRIs, so selective serotonin reuptake inhibitors, and some of the main ones are called sertraline, fluoxetine, and citalopram. And what this figure means here is that compared to the dummy pill, sertraline, for example, the odds of recovering from depression or having a response to the antidepressant were 1.67 times higher in the sertraline group compared to the dummy pill group, and the findings were similar for all antidepressants. However, one of the most important findings from this review of the evidence was actually the limitations it uncovered about the existing evidence base. So most antidepressant trials were actually done decades ago by the time this review was published, and they were done by pharmaceutical companies in regulatory studies for new drugs. The review also found that many of the studies were of poor quality. So 82% were rated by the authors at being at moderate or high risk of bias. And larger, more recent trials tended to produce smaller effect sizes than the older, smaller trials. Also, perhaps most importantly, most trials were of people with severe depression who had been recruited from specialist mental health services. And the reason that's important is that antidepressants, for quite some time and most certainly now, are given to a much broader range of people than were included in these studies. The people who antidepressants are largely prescribed to include those with mild to moderate symptoms of depression. And instead of being treated in specialist mental health services, most people who are prescribed an antidepressant are prescribed the medication from within primary care, so by their GP. So to address these limitations, we conducted the PANDA trial, and the results were published in 2019. And the PANDA trial investigated the effectiveness of antidepressants in the population who are now mostly receiving them. So this was antidepressants being prescribed by GPs in primary care rather than through specialist mental health services. And also in PANDA, we recruited people who had varying levels of severity of depression. So from those who were mildly or moderately depressed up to those who were severely depressed. And so what did we find in the PANDA study? So this table just illustrates the main finding. So we measured depressive symptoms and we measured anxiety symptoms, and the main results were at 6 weeks, so 6 weeks after people started the study, and then at 12 weeks, so 12 weeks after they started the study. And what we found for symptoms of depression actually really surprised us. So we found that the symptoms were 5% lower in the group who took the antidepressant compared to the group who took the dummy pill. And this was a much smaller reduction than we were expecting to see. That reduction had increased by 12 weeks, but we were expecting to see a larger reduction by 6 weeks because most studies in the previous review had seen a reduction in depression symptoms by 6 to 8 weeks. By 12 weeks, depression symptoms were 13% lower in the group taking the antidepressants than the dummy pill. Also, surprisingly, we saw a different pattern for symptoms of anxiety compared to symptoms of depression. What we saw for symptoms of anxiety, so this is generalized anxiety disorder symptoms, so things like nervousness, tension, worry. We saw that those symptoms were around 20% lower in the group who took the antidepressant than the group who took the dummy pill by 6 weeks, and that this effect was still maintained at 12 weeks. So we saw a much larger difference for anxiety symptoms compared to symptoms of depression. So in a more recent study that has been led by one of our colleagues, Julia Piazza, we looked at the individual symptoms of depression and anxiety. And we found early effects of the antidepressant on the main clinical symptoms of depression. So, for example, sad mood, and on all symptoms of anxiety, such as restlessness. And this was observed as early as after 2 weeks of treatment, which is around the time that people usually expect to see a difference from antidepressant treatment. And by contrast, we found that the antidepressant led to an increase in physical symptoms, so such as sleep and appetite problems, and this suggests potential side effects of the antidepressant. So how can these findings be used? So we found that the main benefit of the antidepressant, and this was the antidepressant sertraline, one of the most commonly used antidepressants, during the early weeks of treatment are on reducing anxiety symptoms such as worry and restlessness. Any effect on depression seems more modest and takes longer to happen. But an improvement in anxiety symptoms in someone with depressive symptoms is still likely to be clinically meaningful to the people who take antidepressants. And this is because symptoms of depression and anxiety often occur together. And anxiety symptoms among people with depression have been associated with poor quality of life. And the vast majority of people who experience depression will also experience symptoms of anxiety. So we also found that the antidepressant led to anxiety reductions in a wider range of patients than previously studied, including those with milder symptoms of depression who didn't meet the clinical criteria for diagnosis. So in terms of whether the results that we saw are meaningful to people in terms of experiencing a meaningful recovery in their symptoms of anxiety and depression, we can use something called, which in medicine is called the minimal clinically important difference, or the MCID. And this difference is the smallest change in symptoms that a person would identify as important after they've been given a medical treatment. And this is important for interpreting the results of clinical trials. So when we did the PANDA study, most existing methods of estimating the MCID for depression had not involved any incorporation of the patient's perspective. In the PANDA study, we used the anchor method. So what this means is that we asked participants, compared to when we last saw you 2 weeks ago, how have your moods and feelings changed? And they responded, they're either better or slightly better, the same, slightly worse or worse. And we created 2 different groups based on these responses. So a group of participants who said they were feeling better, coded as 1, and a group of participants who said they either felt the same or slightly worse or worse, which we coded as 0. And this table shows the proportion of people who said they felt better after taking the antidepressant at 2 weeks, 6 weeks, and 12 weeks. So this is the antidepressant group, and this is the placebo or dummy pill group. And we can see that at each time point, a larger proportion of people reported feeling better in the antidepressant group compared with the placebo group. So at 6 weeks, these figures, so 59% of people taking the antidepressant reported feeling better, compared with 46% of people taking the placebo, and 59% again in the antidepressant group at 12 weeks, compared to 42% in the placebo group. So these are patients' own global reports of whether they feel better or not. When we analysed these data using a more complex method, we found that patients taking the antidepressant were twice as likely to say that they felt better and that their mental health had improved compared to those taking a dummy pill. This is an important measure of improvement from the patient's perspective, and it can be used to gauge how meaningful a treatment has been to them. So the patients taking the antidepressant in this study also reported improved mental health related quality of life. So again, quite a global measurement of how they're feeling compared with those who were taking the dummy pill. So this is evidence that antidepressants can produce a clinically important change, at least on average, at least for generalized anxiety symptoms. In another study we did, we estimated the magnitude of the minimal clinically important difference, and we found that the MCID was about a 20% reduction in symptoms after a treatment has been started. So we did observe a 20% reduction in symptoms for generalized anxiety. So a substantial improvement is more likely to happen on antidepressants compared with placebo. But we also know that some people are not helped enough, and antidepressants do not work for everybody. So I'm going to talk now about the second point, which is that in clinical trials, people can often figure out which group they are in because of antidepressant side effects, and this biases the results that we observe. So in the PANDA study again, we asked participants, do you think you are taking the active drug, sertraline, or the placebo drug? And participants guessed which drug they thought they were taking. So what did we find? So this is the proportion in this table of people who thought they were taking the antidepressant. And these data, I'll go through them in a second, but they show that people do guess which arm they are in better than chance. But this might be because people are feeling better, which we know from the previous evidence I presented. We do have evidence that people are feeling better in the antidepressant group, and not just because of potential side effects. So the picture is actually much more complex than it's often portrayed as being. So, for example, at 6 weeks, 19% of the placebo group thought they were in the sertraline group, the antidepressant group, and 46% of the sertraline group thought they were taking the antidepressant sertraline. So people can guess what they're taking, but it could be because they're feeling better, not just because of the side effects. And to show some data on the side effects that we observed in the PANDA study, if we just look at these two columns here for the placebo and the antidepressant, these numbers indicate the number of side effects that people reported experiencing in each group. And you can see that the number of side effects that people reported, we found no evidence actually that they differed across the placebo group and the antidepressant group. That's not to say that people never experience side effects of antidepressants. There are side effects of all medications, but in this study, we didn't observe a big enough difference to find any evidence to say that side effects were more common in the antidepressant compared to the placebo group. So the possibility that adverse effects of antidepressants could lead to unblinding, as we call it, so people guessing which group they've been assigned to, has been raised previously and in many other areas of medicine. If true, this should lead to a difference across all outcomes. And we know in the PANDA study that we saw a difference for anxiety, quality of life, and self-reported improvement measures, but not for symptoms of depression. So this suggests that it's not just people guessing which group they're in that explains the pattern of findings that we saw. So I'm going to finish my section just by making a comment on clinical trials, which are also called randomized controlled trials. So this is where people are randomly allocated to either take the actual medicine or the dummy pill, the placebo. And then they're followed up over a period of time, and any effects of the medication are compared to effects of the placebo. So unblinding clinical trials are the most robust method of evaluating treatment effects that we have available to us as scientists. And unblinding could either be because of side effects or because of improvement. And we think there's more evidence for the latter than for the former, at least just looking at the PANDA findings. And any observational data, so any data that is from studies that are not randomized and not controlled, that pertains to long-term adverse effects or side effects or even treatment effectiveness is likely to be very difficult to interpret. I'm now going to hand over to Glyn Lewis, who's going to present the next section.
Right, hello. And so I'm going to talk really about the third issue which has been raised as a criticism of the existing evidence. And this is about the possible confusion between withdrawal symptoms when people discontinue an antidepressant and relapse of a depressive illness. So antidepressants are used in two ways. They're used to treat the initial, the starting episode of depression when people are feeling ill, but often people take them as a so-called maintenance treatment in order to stop becoming ill again. So the idea is that it prevents relapses if you continue with an antidepressant, even if you're feeling better at that time. And this is an old study now, which illustrated this for one of the first times. And you can see on the right, you've got the patients free from relapse, and you can see the active treatment and the placebo treatment there is indicating that the active treatment are having fewer relapses than if they started a placebo. And a number of these studies have been done, not as many as the studies for the initial treatment, which Gemma described. There's still quite a few, but there are some quite serious limitations with this evidence again. And there are two main points which one can criticize this. And the main one is that the evidence is really only for people within 6 months of starting treatment. So, these days people are taking antidepressants for much longer periods, for months, years, even decades. And yet there is really no evidence at the moment that people taking for that length of time are still getting benefit. And the second problem, as we discussed earlier, is that the studies are quite old and we know little about the people recruited. And we know that the use of antidepressants has changed considerably since a lot of these old studies. So we want to know if the results apply to people taking antidepressants now. So we carried out the ANTLER study, which was now published back in 2021. And in this study, it was a randomized controlled trial, and we compared the discontinuation of antidepressants with carrying on with maintenance antidepressants, just carrying on with your antidepressants. And so we studied primary care patients who've been taking antidepressants for more than 9 months and felt well enough to consider stopping their medication. So the people we recruited did seem to be quite representative of the population we wanted to study, and almost 3/4 of the patients had been taking antidepressants for more than 3 years. As usual in these studies, there were more women than men. And this was the design. So the blue group at the top just carried on with the usual antidepressants at their usual doses. This was a placebo-controlled trial. So we selected a limited number of the commonest antidepressants so that we could make the placebo and the active drug and make sure they were identical. And then the sort of purple group underneath were the group who discontinued. And we had a tapering regime, which for most of the antidepressants was for 2 months, but fluoxetine, which has a very long, it stays in the body for much longer than antidepressants. It was just a month taper. And these are the results we found. So on the left, again, you can see there's the likelihood that people have not had a relapse. And you can see that the discontinuation group had a much higher rate of relapse, about double the rate of the maintenance group. And just to put that into numbers, what we found was that about 56% of those who discontinued relapse during our year's follow-up, against just 39% in the maintenance group. So we found, good evidence that maintenance antidepressants were continuing to provide a benefit, if you like, and reduce relapse rates. But of course, as you can see from those figures, many people still relapsed on their maintenance antidepressant, and many people did not relapse if they discontinued. So I started talking about sort of discontinuation or withdrawal symptoms and whether these could be confused with relapses. So there has recently just been a review of how commonly you might expect discontinuation symptoms after stopping antidepressants. And you can see the summary of this paper here, that about 31% reported discontinuation symptoms after an antidepressant, but also 17% reported similar symptoms after a placebo. So this is about a 14% difference. And it's notable that the discontinuation symptoms, which are very commonly reported, occurred even when people weren't taking an active drug. And probably a better comparison to judge how many people might experience discontinuation were those when you just restricted this analysis to the randomized comparisons. And there was about an 8% difference there between the two groups. The other thing they reported is that some people reported a severe discontinuation in about 2% of those who stopped the antidepressant. Now, what are discontinuation symptoms? And these are the commonest discontinuation symptoms that have been reported. And you can see yourselves that there is a marked overlap with the symptoms of depression and anxiety. And indeed, if you apply depression scales to people who are discontinuing, their depression symptoms go up. In ANTLER, we used a scale which we modified slightly because it was very long. There were 42 questions. We felt that was much too long for our participants. And we picked the commonest symptoms and also consulted people with lived experience to add a few items to the list. And the idea of this scale, called or for short DESS, the Discontinuation Emergent Signs and Symptoms Scale, which is the most commonly used for looking at discontinuation symptoms. People are given this list of symptoms and then asked, is it a new symptom, an old symptom but worse, old symptom but improved, and so on. And if they say it's a new symptom or an old symptom but worse, it's coded as a discontinuation symptom. So what about our results in ANTLER? So these are the number of, or the average number of symptoms that people are reporting. And you can see that at 6 weeks and at 12 weeks, we are getting a difference between the two groups. Those who are discontinuing are reporting higher rates of discontinuation symptoms. But what I'd like to do, though, is sort of step back a bit from, these data, and, what's clear from these results is that people, even on maintenance antidepressants, are still reporting symptoms on the DES. So it's clear that, DES symptoms aren't just withdrawal symptoms. They also seem to be measuring something else. And it's probably related to depressive symptoms, given the overlap in symptoms we've seen. But what are withdrawal symptoms and why should people get them? So the assumption is that when somebody has taken an antidepressant for some time, there is the brain has to adapt to the presence of that drug. And there is evidence from experimental animals and humans that the brain does change. You might get more receptors or less receptors to adapt to the presence of this drug. And so that when you withdraw that drug, that brain adaptation has to get back to normal over the next period. And the length of time that takes in a human is not really known at the moment, but it is probably in weeks, if you like, before the brain fully gets back to normal once the drug has been removed from the body. So to my mind, that means that the withdrawal symptoms are likely to be the opposite of the symptoms that are improved when you first take the antidepressant. So in a sense, I think it is expected really that one would have a big overlap between the symptoms that are improved by depression, by antidepressants, like the anxiety and depressive symptoms we've seen, and that they should increase, if you like, when people are withdrawn from the drug. So in practical terms, what does this mean? And I think what's important to acknowledge is that, people do experience these withdrawal symptoms. Sometimes these are severe. Often for clinicians, the severe withdrawal symptoms seem rather uncommon, but of course, antidepressants are given to so many people in aggregate, that is still a lot of people. And it's important that people are supported during the period when they are choosing to stop their antidepressant. Psychological treatments can help, and longer periods of tapering can also help. So finally, I just want to discuss the sort of implications of this work and what they mean, taking Gemma's and my presentations together. So the first point, I suppose, is that for many people with depression, antidepressants will be of benefit and will be well tolerated, but they won't help everyone. And of course, it's important that they are stopped if they're not helpful. The second point is that, no studies are perfect, but on balance, I would say that we do have very good evidence about the benefits and harms. And our recent studies really support the way that antidepressants are used at present. So there has been a change in the way that antidepressants are used, if you like, a sort of broadening of the indications. More people with milder symptoms have been given them. But we've tried to mimic how they're currently used in our studies, and we've still found benefit overall and on average. And there will still be people who do not benefit, but unfortunately at the moment we don't know how to identify them. the third point is really that antidepressants are also effective in maintenance treatment. But again, many people can stop antidepressants without experiencing relapse. Again, we're not sure who those people are, and perhaps, you know, an important point to take home is that when we're carrying out these randomized studies, we are dealing in averages and, you know, saying that, you know, on average you will benefit, though we can never be sure in an individual case. And lastly, it is difficult to distinguish between withdrawal symptoms and depressive symptoms. And it isn't clear to me that we'll ever get to a position where we can completely separate the two and be clear about what is withdrawal and what is a relapse. And I think what's important is that clinicians and patients during that period of discontinuation, you know, work together and that people are correctly supported and properly supported to try to stop their antidepressants. So thanks very much. That's the end of our talk. I'd just like to mention our disclosures, which are there. And also finally, we're part of a very big team of people who worked on these grants. They were funded by the NIHR, which is the NHS research programme. And I'd just like to acknowledge the tremendous support we've had from our colleagues. Thank you very much.
Thank you both, Gemma and Glyn, for really fascinating talks. And we have had a number of questions that have come in. So this is clearly a topic that is raising a lot of interest. And I'm going to be putting these questions to you. I suspect that you can sort of decide which of you takes them first, and you might each want to respond to some of them, and some of them you may decide that it's better responded to by Glyn or by Gemma. So the question number one is, taking antidepressants is linked to increased suicidal thoughts and behaviors. What are your thoughts on this, and how likely is this to be causal?
Shall I take that one, Gemma? Yeah. So the main evidence that there is an increase in suicidal thinking is for younger people. There is not enough evidence at the moment to know whether there is an increase in actual suicides, but certainly the evidence at the moment does suggest that in younger people there is this sort of early increase in possibly agitation and suicidal thinking. So the guidance is really that during that period when young people are starting medication, that they are closely monitored by their doctors, just in case that kind of thing happens, and to make sure that the people are properly supported during that early phase of treatment.
Thank you. It's very, very clear. There's also a question regarding whether what people's perception of what the effect of the medication is before they start antidepressants, whether that impacts their outcomes. So what the expectations are of how the antidepressants work versus reality.
I think that's a very interesting question. I'm not sure, to be honest, if there is evidence on that. Obviously, once the study has started, the placebo group would account for any beliefs that patients have about how whether the drug is going to work or not, how that affects their symptom response as the trial goes on. But prior to the study starting, I'm not sure. I don't know if Glyn knows.
No, I think I agree with your answer, really, that in trials, that's the idea of the placebo group, because all the symptoms are very common, and it's very difficult I suppose one point to make is that, which I sort of made in my talk, is that we are dealing about averages here rather than necessarily with individuals. Doctors are in a position of saying, I recommend this to you because on average people like you would benefit, but we never really know whether it's going to benefit that individual. And and if people do get better, we don't know whether it's the drug which has really made the difference either. So it's, it is a limitation of what we can, of what we can research effectively. And obviously, ideally, we'd like to have much better predictors of who gets better with what. But at the moment, that's sort of areas in its infancy. But clearly, a lot of people get better on the placebo group in these studies without any actual pharmacological intervention.
But more gets better on the trial. And I guess the hope is that as we get better and more precise methods, that we will be able to, with more accuracy, come to individual prediction, which would allow to either prescribe for psychological or something else in a way that suits that particular individual.
That would be the ideal situation, but I'm sometimes not that optimistic we will get to that situation. Yeah. And it hasn't really happened very often in medicine that people have been able to predict, really predict which treatments people will get better on, though there has been some advance in cancer, certainly.
Yeah. Now, there's a question about many people now taking antidepressants for years and decades, and what is the state of the evidence on the potential harms of long-term use? And I think there's a related question as well. Is it possible that something that makes you feel better in the short term, and this could, apply to alcohol even, could that make you worse in the long term? So, what's the evidence in relation to antidepressants?
Yeah, maybe I'll just respond, and then Glyn can also respond. So I think it's a very good point. We know that people stay on antidepressants for several years often. So I think in the PANDA study, 75% of people had been taking had been receiving antidepressants in the ANTLER study, 75% of people had been receiving antidepressants for 3, 4, 5 years or longer. There's definitely a lack of studies which have followed people up over time to investigate any potential benefits or harms of staying on antidepressants. So in the ANTLER study, we went up to 12 months follow-up, but there are hardly any, no trials really that have followed people beyond that time period. But in the ANTLER study, we did see that up to 12 months of follow-up, there was a decreased risk of relapse amongst people who stayed taking their maintenance antidepressant compared to people who discontinued their maintenance antidepressant, but also that 44% of people who discontinued their antidepressant could do so without having a relapse, at least within the 12 months follow-up. But there is a lack of studies with longer follow-up periods.
Yeah. The only thing I'd add to that is that, it is possible to look at longer term follow-ups using large databases of patient records. And this observational data suggests that people taking antidepressants do have poorer outcomes. But the problem with that data is it's not randomized.
Yeah.
So we're not quite sure whether it's the other characteristics of those people who might be taking the antidepressants which lead to the poorer outcomes. And indeed, in most data like that, the people who take the treatments seem to have worse outcomes, even though the randomized evidence suggests the worst. So it is very difficult to know about the long-term adverse consequences of these drugs in a very confident way, and to be sure, oh yes, that has been caused by the drug or not. So there is a bit of uncertainty, but I suppose from a more clinical perspective, people do take them for years and years and years. Clearly those people are the ones who are tolerating them. If people do have adverse effects, they'll stop taking them. But there are lots of people who do take them for a long time and say they're very well tolerated.
And I guess just if we try and unpack for people who are not psychiatrists, I guess what you're saying, Glyn, is that you're perhaps more likely to take them for a long time if you have more severe depression, and therefore you might potentially be expected to have worse outcomes as well.
Yes, exactly. Yeah. So, in the general population, if you do a survey, the people taking antidepressants will be more depressed than the people not taking antidepressants, because, you know, clearly that's why they're receiving antidepressants.
Motivating.
Yeah, exactly.
Great. Now, there's a question of, there are other estimates that find that the minimally important difference is much larger than what you find in your studies. How would you explain that difference?
I'll let you do that one, Glyn.
Yeah. So what's different about our approach is that we have taken a patient-centered approach. One of the earliest estimates of the MCID in depression was, you know, in the most literal sense, dreamt up by a committee. And so people, you know, sat in a committee room and said, we think it's 3 points on the Hamilton Depression Scale. And so, since that time, I think people have realized that we do need to have that kind of patient perspective in these estimations. And so the so-called anchor method, which Gemma described, is probably the best method we have at the moment to get an idea of what these differences are. And so, and as we've discussed, our best guess at the moment, if you like, is that about a 20% reduction in scores on the scales that we use in these antidepressant trials indicates a difference which people then say, I feel better. And so it is, I suppose one of the points about our work on MCID is that it's not an absolute score. Like that early consensus rating I mentioned, it isn't 3 points, it's actually a percentage change. So we find that people who score higher on our scores and they have more symptoms need a larger drop in scores to feel better than those who are less severely affected. I think this is a better way of doing it. No way's perfect, but I think using these methods and, we're continuing to look at this question and try to get, better data, larger data sets and so forth to refine these estimates. I think this is a better approach for trying to estimate that clinical importance than some of the previous methods that have been used.
I think what both your talks and the answers to the questions really, I think, to me clearly show is how complex this issue is and how the headlines that we see are often just very misleadingly simplistic. So they're quite complex things that you're grappling with in order to try and understand, what the effects are, who benefits. It's not a kind of a black and white answer.
No, I agree. And in fact, one point which perhaps we should make is about this issue of the polarization that has occurred within this area. And, Gemma referred to those newspaper headlines and the comments we get on, Twitter or X on this area, which are very polarized. And, what we're trying to do is say, well, there are, we can do studies to try to answer these questions. And they're sometimes not, we don't get a black and white answer out of it. As we've indicated, it isn't that everyone gets better on antidepressant or no one. It is somewhere in between. Yeah. And those differences, like between the 62% and the 49% in Panda who feel better on the active and placebo, those are the kind of figures we need to provide people, patients and doctors, so that they can make the judgment about whether it is worth taking an antidepressant or not.
Now, there are a few questions about tapering. You commenting on the fact that longer tapering can be helpful and whether you think the ANTLER trial results would have been improved by longer tapering. And then there is a kind of a related question where someone says they've been tapering off for 10 years and they're aware of the hyperbolic cough and need to taper down to very small amounts. So what's your opinion on this? So maybe you can quickly tackle those. There are more things coming in.
Yeah. Shall I take that one?
Yes, I think that'll be good.
Yeah. So again, there isn't a lot of evidence that tapering helps, but common sense suggests it should help, and clinically it does seem to help. And so the tapering regime we adopted in Antler was over about 2 months, but we were quite limited in how we could taper because of the availability of the medication. So at the time we did that study, we couldn't get very small tablets of sertraline, 25 milligrams. They are available now. So we were quite limited in how, so we had 2 steps basically. We went from 100 to 50 and then to 50 every other day. And I think clinically, if people are finding it difficult to follow that kind of regime, which clearly for many people was okay, then you do need to get more specialist help and use perhaps liquids, or people talk about tapering strips, which are very difficult to get hold of in the UK, in order to sort of take that dose down from the low doses available in the standard tablets available. So, you know, there are people who do require this prolonged tapering period, as some of the, you know, people putting in the questions said, but, you know, many people don't need that. And it's really, as I said, you know, if people are discontinuing, it's important that they are supported. If they are finding it difficult, you know, going for a more slower taper would be important.
Great. Now, there's a question about one of the criticisms of antidepressants being that they're based on, in quotes, chemical imbalance theory that is unproven. Does it matter?
Yeah. So, you know, I think there's, you know, there's good evidence now, and, you know, we've known for some time that depression is, you know, probably never due solely to a chemical imbalance in the brain. And we do have a poor understanding of the mechanisms that underlie how antidepressants work. If we understood those mechanisms better, then it could lead to us being more able to refine treatments and perhaps predict treatment effectiveness. I'm not sure that it does matter really pragmatically in terms of people getting prescribed antidepressants and people who experience a benefit from those antidepressants. They likely work in a much more complex ways than simply, you know, affecting the chemicals within our brain. So I think it would be helpful to understand better how they work, but I'm not sure that it does matter really for people being prescribed and who are experiencing a benefit from them. Glyn, do you want to add to that?
Yes. Well, the other point, I suppose, is that, you know, personally, I wouldn't use the say you're correcting a chemical imbalance if you're treating somebody with an SSRI. I don't think that's appropriate. We certainly don't know that. And the other point is that, you know, sometimes it's presented that people discovered serotonin was important in depression, so they developed SSRIs. In fact, the reverse happened. People discovered SSRIs, that they were effective, so they then said, maybe serotonin is important in depression. So, you know, it isn't as though the SSRIs were developed with that theory in mind, not at all. It was a bit of a, you know, a lot of the antidepressants were kind of discovered by luck almost. But it's just that because they work on serotonin, the serotonin theory or hypothesis was developed. And it's true, actually, of a lot of medical interventions. I suppose that's the other point. You know, we don't really know how paracetamols work, but we still take them. So, you know, I think it would be good to know how they work. One of the important points of the work, you know, that we've done and others is that these, you know, these treatments are not effective for everyone. There are a lot of people who are not getting better on antidepressants or on the psychotherapies, and we need to improve the treatments we offer people. So knowing more about these mechanisms, I think, might help us to develop new things and to make sure we get better outcomes for our patients.
And I guess maybe a good thing to also remind people is that there is often this funny dichotomy about biological, which is thought to be genetic or neurochemical, and then psychological, where I don't know where people imagine it flows, because it's your how you think and feel is a product of what your brain is doing. You can impact it by exercise, you can impact it by sleep and all sorts of things. So there is nothing more or less neurochemical about taking pills than there is about going for a run. So most of these things have an impact on our behavior via brain. So I think that's probably a good thing to sort of think about too.
And well, just to make one final point on that, Essie, is that all the evidence suggests that psychological treatment plus antidepressants is better, is more effective than either alone as well. So
yes,
again, we shouldn't think in silos.
Absolutely. And I think some interesting work by Catherine Harmer and others showing that taking the antidepressants may then allow you to process social information, for instance, in a way that will then help you have more positive social interactions that have effect over time. So it's complex. There is, I think, time for maybe one, possibly two, depending on how long the answer is, questions. So there's a question about many people being left on antidepressants with no GP follow-up, and what are GP guidelines for reviewing these patients?
Yeah, I'm not sure what the guidelines are.
Yeah, I can't remember now, but clearly people do need to have, any medication they're on for long term, they need to have regular reviews, and a discussion about whether they need to carry on taking those medications. Obviously the ANTLER study sort of was particularly looking at people taking long-term antidepressants who felt reasonably well, and in fact the entry criteria they were thinking, should I or not take the antidepressant, because clearly they'd be randomized to discontinuation as a possibility. So in that group, on average, people are still benefiting, but there are clearly lots of reasons why people want to stop any medication, including antidepressants, and obviously the figures we've got from ANTLER help people make a judgment about whether it's worth taking that decision in their case.
I just wanted to add about the REDUCE study, which was published recently, had quite a similar figure to the ANTLER study in terms of around 40% of people who discontinued their antidepressant didn't experience a relapse during the follow-up. So although they do reduce the risk of relapse for a substantial proportion of people, it probably is worth discussing with GPs the possibility of attempting to discontinue with appropriate support and monitoring.
Now, there's a question about difference between depressive symptoms and anxiety symptoms, and I thought that would be an important one to tackle, given that you presented data pertaining to both.
I'm sorry, what is the question?
What is the difference between depression and anxiety symptoms?
Okay, so the core symptoms of depression are low, sad mood, loss of pleasure in things that people usually experience. The core symptoms of anxiety are things like nervousness, worry, and tension, generalized anxiety disorder in particular. However, the symptoms of depression and the symptoms of generalized anxiety disorder, although many of them are different, many of them also overlap. And 50 to 60% of people with depression also experience symptoms of generalized anxiety disorder. So there is a strong overlap between the symptoms of these two mental health problems.
And we of course know that the same overlap, there are overlapping risk factors for both as well.
There are overlapping risk factors certainly for depression and anxiety. To be honest, I'm not aware of sort of any risk factors that are differentially associated with depression and not generalized anxiety. There are other types of anxiety which are thought to be a bit different, like panic and phobia and things, but generalized anxiety and depression certainly a very, very similar profile.
I think we're coming very close to the end now. So I wanted to thank you for attending the lunch hour lecture. And if you would like to take part in current World Mental Health Day Workplace Health campaign, or if you would like to stay up to date on future campaigns and information, links will be sent to you after the event. The next lunch hour lecture will take place on 24th of October on the US election, its stakes and implications, which I am sure will be many. So I hope to see many of you there, and thank you for coming, and thank you to our speakers who gave incredibly clear and informative talks that clearly generated a lot of conversation. Thank you.